this discussion highly engaging and meaningful. I invite all the participants in this online platform. I also extend my sincere gratitude to the leadership of IMA Kerala State Branch for organizing and supporting us in organizing this webinar. Let me first invite our beloved State President, Dr. Menon sir, to say a few words and inaugurate this session. Menon sir.
Very, very good evening to respected AMS Chairperson Dr. Deepa, Secretary Vinod, Faculty of the Day Sonia, and Chairperson Lata, Dr. Lata, President-elect Gopi Kumar, other senior leaders and esteemed delegates who are attending this session, the Zoom and the other live streaming media. As we all know, obesity is a complex chronic disease impacting multiple aspects of daily life to be addressed before complications and comorbidities start. And it was recognized in 1948 by WHO as a health issue and later by American Medical Association 2013 only. And in India in general, we have got malnutrition issues. And here in Kerala, I think we have got the maximum burden of childhood obesity and metabolic diseases related to these obesity issues. And according to the data presented in Indian Parliament, Kerala ranks first in India for abdominal obesity at 58.2%. Oral obesity rate is just 43.6 in India. This highlights a distinct genetic and physiological vulnerability. A majority of population carries dangerous visceral fat, even when falling into normal global weight ranges. We are all supposed to be slim, the Indian or Kerala citizens mainly, genetic type. But anyway, obesity is on the rise. And I don't want to elaborate on the scientific aspects of these things. We have got a wonderful speaker, Sonia Suresh, who will be elaborating on this topic and telling us the latest trends with regards to scientific aspects and the corrective measures. And I hope the session will be very fruitful for everyone. I hope that there are a lot of other delegates also attending in the YouTube and Facebook media. Meanwhile, let me congratulate Dr. Deepa for taking up the topics frequently as I was frequently suggesting her to take up topics, mainly because of there are contemporary issues which are pertinent. So it should be taken up and nobody should hesitate to come up with the topics and have sessions for the members, because members are to be updated only by our academic cells, that is the AMS and CGP. The branch CMEs are not focused on a particular thing, but we have got common topics which are relevant to the public health scenario of Kerala. And we have to take up such topics and have sessions which are not just for super specialists and specialists, for the general practitioners and physicians in general, so that we'll be able to combat all the issues in a more scientific way. I'm happy that Deepa is doing it very well, supported by Vinod also. And are you hearing? Yeah.
Yes, sir.
No and moreover, I was also suggesting some sessions on this hantavirus and the Ebola issues that is also coming up. I think Deepa is planning to arrange those things as well. Overall, I'm very happy with the activities of AMS. Congratulations to Deepa and Vinod. And let us go over to the scientific session as such. Thank you very much.
Thank you. Thank you so much, sir. Now let me invite our chairperson for the session, Dr. Lata. She has 21 years of experience in health service, presently working as HOD, Department of Internal Medicine, KIMS Street Hospital, Kannur. Her areas of interest are diabetology and infectious diseases. Let me invite Dr. Ledda to chair the session.
Okay. Very good evening to all. Respected President M.N. Menon sir, President-elect Gopi Kumar sir, Chairperson of AMS Kerala State Branch, and Dr. Deepa Madam, and all the delegates, a warm welcome once again. So today, definitely, this webinar is we can say the need of the hour when we are having lot of newer therapeutic agents which has come to the market with lot of price, what do you say, differences. And any scientific forum, obesity is definitely is a big discussion now. We all know it's no longer merely, what do you say, a cosmetic concern or just a lifestyle disease, but it's a chronic relapsing disease which has multifactorial causes, and it has a significant metabolic, cardiovascular, endocrine, orthopedic, psychological, and oncological consequences. And like how Menon sir said, Kerala is becoming the obesity capital in India. India as a whole, we are witnessing an increase in the prevalence of obesity. And as clinicians, we are increasing seeing cases. We are seeing obesity not as a isolated disease, but as a part and parcel of diabetes, hypertension, sleep apnea, PCOS, fatty liver disease, hypertension, cardiovascular disease, and all. And so today's discussion, which this aims to move beyond the simple advices like eat less and exercise more. We are going to discuss the various aspects of obesity. And for this, definitely the topic for today, beyond stigma, understanding obesity, we have a speaker who is, what do you say, who's a very eminent speaker with lot of experience. So I would like to introduce Dr. Sonia. So she did her MBBS from Government Medical College, Nagpur, DNB Internal Medicine, trained at Government Medical College, Trivandrum. She has 26 years of experience as consultant physician with special interest in diabetology, and she is active on social media with more than 200 patient education videos in Malayalam, English, and Hindi. And along with that, she is one of the master trainers in communication skills. So we'll move on to today's topic, beyond stigma, understanding obesity. So welcome, Dr. Sonia, for this session.
Thank you very much, madam. Thank you, respected State President-elect Deepa Madam, Lata Madam, and all the esteemed guests who are here. Hope I'm audible and visible. So the topic is beyond stigma, understanding obesity. We know that a lot of GLP-1 RAs have come to the market and they are a multi-million industry. And some people are looking at them as the final solution or the holy grail. And some think it's a disaster. But obesity, as we all know, there's a biology behind it. And there's no magic in GLP-1 RAs. We need to understand the biology of obesity and how to take care of obesity. So I will touch upon various aspects of obesity with a special reference to GLP-1 RAs, which are the newer molecules in the town. So as we all always think, obesity is not a moral failure. It is not overeating. It is not lack of discipline, but it is an evolutionary success. We know that human biology is basically that of starvation and hunger, which shaped the early human survival. We were all hunter-gatherers, and there was no free flow of food. The hunters would hunt, and then for days together, there would be nothing to eat. They would be famished, and there would be sometimes plenty. So people who could conserve this energy in the form of fat survived, and rest who could not perished. So this is the biology which helped us evolve. And so we should be happy that we are the successors of this, the people who could conserve energy and survive the very difficult times. So this biology is ancient, but the environment is new in the sense that there is abundance of food and abundance of calorie-rich, calorie-dense food. So this is precisely the evolutionary mismatch where the biology is ancient, where we need to conserve energy, conserve it in the form of fat, but there is abundance of food where we really don't need to conserve. So this has shaped into, this has brought in the epidemic of obesity. So it is definitely not a moral failure. So whatever the concepts may be of basal metabolic rate, etc., this is basically a energy balance and its regulation. So this is the first column is that of a balanced state. There will be a positive energy balance when the calories in are more than calories being expended. And there would be a negative balance when the calorie expenditure is more. Very simple. And this very simple thing goes in for the obesity. Obesity is defined as the abnormal or excessive fat accumulation that may impair health. Further clarifying that the fundamental cause of obesity and overweight is an energy imbalance. Obesity index is the body mass index above 30 and is a chronic state. Above 30 is by the Western standards. But when we look at obesity as treating physicians, clinicians, obesity is a chronic, relapsing, and progressive disease process characterized by abnormal and excessive adiposity. The relapsing word is very, very important. But because whenever we use a drug, there's a question, how long should we use? And we have no answer to that because this is a relapsing disease and a progressive disease. These are the normal guidelines. But its complications are hard to miss. There's 230 plus complications involving every organ system. Just to name a few, there can be an increased risk of stroke, congestive heart failure, ischemic heart disease, PCOS, major depression, diabetes, myocardial infarction, of course, MASLD, GERD, obstructive sleep apnea, hypertension, and osteoarthritis. These are just a few. Now, prevalence of obesity in India, this is a very relevant study known as the ICMR India Diet 17 study. It shows that generalized obesity, 28.6%, and abdominal obesity is to the tune of around 40%. And what is alarming is childhood obesity, which is nearly, between 10 to 20%. So these are the principal factors leading to obesity, from the environmental to genetic to social to psychological to lifestyle factors, etc. To name a few, among the biological factors, there is genetics, which plays a lot of role. Some people say that we are all fat. So, please don't try to slim us down. We are all fat, right from my grandmother to mother to me. Then there is a lifestyle where we have the couch potatoes, where they don't exercise and eat calorie-rich food. And there are some people who are forced to take up this lifestyle, like like the IT professionals. They work for so many hours sitting down, and there is very little exercise. Then the socio-economic factor. We know that, the calorie dense and the trash food or the fast food is always cheaper than a healthy food. So there are people who undertake travel very often. There are youngsters who opt for, you know, uh, less healthy fast food rather than healthy food, uh, just to conserve money, or just to, save up some money. Then there are socio-demographic factors, and the major factors are social factors. We know that whenever someone is fat, we label them as lazy, we label them as overeaters, indisciplined, which is not true, because there is a definite biology behind it. And this social stigma leads to depression. People don't like to get out of houses. They just stay inside, and they don't want to face people. They don't want to face the medical reality. They don't even go to a medical practitioner to resolve the issue. Then there are all the eating disorders, which are part of psychological factors. Then uh, there are some health factors, some drugs that people are using, etc., and environmental factors. I love morning walks. I want to walk, but there are a lot of stray dogs. There are no proper footpaths, etc. So there are a lot of social factors also, where we don't pay much attention to. Are we creating an environment conducive to exercise for people? Like we have the Finland study, wherein the diabetic and pre-diabetic patients, one set was given metformin and another set was given a good lifestyle modification. But then the government made every possible change to make people exercise. They created biking pathways, etc., and the net result was that lifestyle modifications were really, they had a spectacular effect on top of what could be achieved by metformin. So these are certain factors which again impair exercise. Whenever you ask for a morning walk, they say, ayo, there are a lot of stray dogs, പട്ടിയുണ്ട്, എങ്ങനെ നടക്കാനാണ്? മരിക്കുന്നതിലും പതുക്കെ ഡയബറ്റീസ് കൊണ്ട് മരിക്കുന്നതല്ലേ വണ്ടി ഇടിച്ച് മരിക്കുന്നതിനേക്കാൾ ഭേദം. So all these arguments we hear when we tell the patients to have a morning walk. Now, coming to what should be named as obesity, what should be termed as obesity. These are a few obesity indicators wherein we have BMI, which we will soon see why it is not very so good an indicator in the Indian context. Then there is a waist hip ratio. Then there is a ABSI, which is a body shape index, and BRI, that is body roundedness index, etc., etc. So I'll not go into minute details of this, but by and large, it is the BMI which we use as an indicator. This is the WHO and Asian criteria, wherein underweight is something below 18.5 BMI, and obese is something above 30, wherein 25 to 29 is considered overweight, and morbid obesity is beyond 40, and super obese is beyond 50. So these are the BMI classifications according to WHO. But if we take this anthropometric measure, that is the waist circumference, it is a better predictor of obesity-related health risk. People with large waist are at increased risk even if BMI is normal. That accounts for central obesity, or dysmetabolic fat which gets accumulated inside the tummy. So these are the levels by Western standards, men and women. But by and large in India, we take as more than 90 in men and more than 80 in women as a health risk. So whenever you take a waist circumference or waist hip ratio, we classify people into two types, apple type or pear type obesity, where in apple type, you will have a higher waist hip ratio and the abdominal circumference would be more. Whereas the pear-shaped type, you will have the pelvis would be wider, and but that is, cosmetically may not look nice, but that is better than having apple type obesity. Now, in the Indian context, we need to redefine obesity beyond BMI, focusing on body fat. And there is a concept of thin fat Indian, wherein we have understood that Asian Indians have more body fat at a lower BMI, and they tend to develop comorbidities, mainly type 2 diabetes, at a much lower BMI. So anything about 23 kilogram per meter square can be considered as stage 1 obesity, and stage 2 obesity is a BMI more than 23 with type 2 diabetes and cardiovascular disease or some similar risk factors. So Indian context, a much lower BMI contributes to obesity. That is the concept of thin fat Indian. An Indian who is thinner than the Western counterpart is actually fatter in terms of having a dysmetabolic fat. Now, management strategies for obesity. We have the nutritional therapy, physical activity, pharmacotherapy, bariatric surgery, nothing new. Everyone knows this. Now, 5A's approach to obesity management. This is very, very important. Ask for permission to discuss weight, not to be judgmental. Many times, even the medical personnel, the dietitians, the exercise trainers, they become very judgmental. Let us not do it. Let us not put a finger on their sore area. Explore readiness for change. That's most important, just like smoking cessation or alcohol abstinence. It is the readiness for change or motivation to change that is important. Assess their part of story. They may have lack of time, like I had an obese young lady who is immediately postpartum. She's already started working after her delivery. She has night shifts, then daytime she has to take care of the baby and the household work. So where should she fit in her exercises? So there are these real life stories which we need to listen to. Then we need to take into consideration the dietary preferences. They say that it's easier to change a religion, but it's not easy to change a diet. People are so it's an emotional thing, whatever they eat and what they like to eat. Then assist with drivers. There are certain drivers where you motivate the patients, and there are certain barriers like the stigma, the bullying, or the marginalizing they have faced. We can see that in schools, colleges. We can see that in workplaces where people get marginalized because of the stigma of being obese. So there may be some traumatic incidents in their life which they need to speak up, and which we need to, make them speak up. Agree on goals, reasonable goals for a personalized, sustainable action plan. This is very important. We have to be empathetic to each and every person who is motivated to lose some weight. Now, weight and nutritional therapies go hand in hand. I'm sure I'm not offering anything new in this. This nutritional principles have to be evidence-based. There are hundreds of diet fads which are going around the town, but we should give them something that is evidence-based, healthful quantity wise and quality wise. Patient adherence is important. As I said, totally changing over to another type of diet may not help. Patient agreement is important. Basic principles are limit sodium, alcohol, and saturated fats. Limit simple carbohydrate. Instead, add more complex carbohydrates. Prioritize healthful whole foods. Avoid high energy dense foods, which is sometimes difficult because unhealthy food comes at a lower price. Avoid ultra processed foods, soft drinks, etc. And patient adherence. A weight loss of more than 15% has been associated with remission of type 2 diabetes in individuals with overweight or obesity and relatively recent onset diabetes. This we have been talking about. I wish Dr. Srijit was there because he's been talking about this for quite a while, and it is doable provided the diabetes is recent in onset and the person is motivated in losing more than 15% of weight, which is easier said than done. Weight reduction through carbohydrate restricted nutrition in individuals with pre-obesity, obesity, and diabetes can remit diabetes. There is a remission data, there are remission studies. So definitely this is doable, but not easy. Now, coming to physical activity, we have to keep it very simple and safe, use proper metrics to assess the progress, establish a routine, healthfully, engage in healthful sleep. Sleep is very, very important. Sleep, 7 hours of sleep is important in preventing lifestyle diseases. It, to an extent, helps in maintaining the leptin ghrelin system. As you all know, ghrelin is the hormone which tells you are hungry. It sends that hunger pangs or hunger messages to the hypothalamus. And then there is leptin. Leptin is a hormone which says enough, you are done now, enough, you stop eating. So as it is as the obesity increases or the obesity increases and the adipose tissue increases, there is more and more leptin. So we should be getting more frequently the signal of enough is enough. But in obese patient, unfortunately, what we see is a leptin resistance. So physical activity is very important in maintaining this leptin ghrelin balance, and there is something known as overload muscles. Look, I'm using a dumbbell of 2 kilos, doing 15 repetitions each day, and I'm doing it again and again and again every week. That wouldn't help me. Either I have to increase the number of repetitions or I have to increase the time of the weight. And similarly, when I walk, I have to either increase the intensity or I have to increase the time. So this is overloading muscles, which is very, very important as far as an exercise is concerned. So whenever we talk about exercise, there has to be an aerobic component and a muscle building component. And resistance exercises are very, very important in this context. In addition to physical activities, we have something known as a non-exercise activity thermogenesis, which is called NEAT, not the NEET NEAT, which is no less than a fiasco now. This is NEAT NEAT, wherein whatever you do in your daily routine, like just standing, doing some kitchen work, doing some simple gardening, all this would contribute to some thermogenesis, which is not a conventional exercise, but an activity which helps in thermogenesis. 5,000 or 10,000 steps per day and or that alone may not suffice. You should add 150 to 300 minutes or more of intensive, moderate intensity aerobic activity per week, and resistance training at least 2 times a week. This is again not very easy to achieve in the beginning, but with some motivation and some guidance, people do achieve it. Plus, we cannot underrate the role of non-exercise activity thermogenesis. Keep an active lifestyle. Now, coming to pharmacotherapy, I would like to bring to your notice that whenever we embark on pharmacotherapy, please see to it that patient is not solely relying on pharmacotherapy. He has to adjust his lifestyle. He has to improve his exercise time. He has to improve on his diet, and then only we should go ahead with pharmacotherapy. This is the pharmacotherapy that was ever available for addressing obesity. We had orlistat, which is a gastric and pancreatic lipase inhibitor, but it did not stay well with Indians. One thing is we are high on carbohydrate and not on fat. So really, what could contribute, what weight loss could be contributed by orlistat was very questionable, plus the fat indigestion issues and oily stool, etc. Then there was phentermine with topiramate. Again, it was contraindicated in glaucoma, hyperthyroidism, hypertension, etc. Naltrexone, bupropion. Again, it was the side effects were very comfortable. People were not very comfortable with these drugs. Acute opioid withdrawal could happen, hypertension, seizures, etc. Then came the GLP-1 RAs, liraglutide, which is a once daily injection, which has been there in the market for some time. And all GLP-1 RAs have a class effect. We may have some evidences in favor of one molecule and some less evidences in favor of another molecule, but by and large, this is a class effect. And a family history of medullary thyroid carcinoma and multiple endocrine neoplasia syndrome is rather a contraindication, and so is pregnancy and lactation. So liraglutide, semaglutide, tirzepatide, wherever you have this tide, these are all GLP-1 RAs. So what do GLP-1 RAs do? We'll just go into it. GLP-1 RAs is the next big thing in obesity management. As I said, that we thought something that it is an answer and something it is a disaster, is a pharma gimmick. But I think there is a definite biology behind it. There is beyond weight reduction, they give us CV protection and HbA1c reduction in diabetics. This is the hero as far as the GLP-1 story goes. This is a Gila monster. This is a lizard which is found in the deserts. And we know how the arid climate of desert is with very scanty food. And this fellow could survive for, years just having a meal a couple of months or 2 or 3 times a year. So this was very intriguing. And what contributed to the satiety and the lack of hunger in this lizard was something known as exendin 4. So this exendin 4 was studied further and further, and we found that we have something similar. That is GLP-1 or GIP-1, which we call incretin hormones. These are some hormones which are secreted in the small intestine of the human beings, and these are stimulated by food in the intestine. But now by using GLP-1 RAs, whatever the advantages of our native GLP-1 RA, which was there only when there was food in the intestine, is being given throughout the day. So that is what GLP-1 RAs precisely do. So these are the various pharmacotherapies wherein we can see that the GLP-1 receptor agonists, they give the best sort of weight reduction to the tune of 20%. Now, this is a molecule terzepatide, which has a double effect. It inhibits the GIP, that is glucose-dependent insulinogenic polypeptide, and the glucagon-like polypeptide 1. So it's a dual agonist. And it has what it does. It increases the satiety, increases the insulin secretion, decreases the glucagon secretion, to an extent preserves the beta cell, reduces the beta cell apoptosis. There is a delayed gastric emptying, which contributes partly to the benefits and partly to the side effects by giving rise to nausea, fullness, lack of appetite, etc. There is a reduced hepatic glucose production. There is an increased insulin sensitivity. So whatever is beneficial in an obese individual, in a diabetic individual, is being carried out by this molecule. So it has an anorexigenic effect, and it promotes, it is advantageous in type 2 diabetes treatment. So please note that tirzepatide acts on both GIP and GLP-1. Now, we know that in type 2 diabetes, we used to name only 3 factors. That was known as the ominous triad of beta cell apoptosis, impaired gluconeogenesis, and insulin resistance. But later we came to know that there is a whole octet in diabetes pathogenesis. And most of the factors of 7 out of 8 pathways of the ominous octet are taken care of by GLP RAs. Like there is a decreased insulin secretion in obese diabetics, increased hepatic glucose production, increased lipolysis. There is an impaired appetite regulation. Like I told you about leptin, ghrelin, there is a leptin resistance, increased glucagon secretion, decreased incretin effect, and decreased glucose uptake by the muscles. These 7 pathways out of 8 are taken care of by GLP-1 RAs. So your tirzepatide is marketed in the name of Mounjaro, and Cipla is marketing the same thing in India in the name Yorpeak. So this is how you use it. You start with a small dose and take your time, take it, after 4 weeks, you can increase the dose, provided the patient does not have the GI side effects. The GI side effects would range from nausea to a couple of episodes of vomiting, to constipation, to fullness, etc. But in patients whom I have used, the smaller doses hardly give rise to any side effects. And once you are confident that the patient does not have any major side effects, you can go ahead with next dose, that is 5, 7.5, 10, 12.5, and 15. In the Indian context, we see that 10 to 12.5 gives a good weight loss to most of the patients. And recommended maintenance dose is 5 milligrams to 10 milligrams in most. 15 milligrams to be maintained is, we're just learning about these drugs. So by and large, the literature or Indian experience says that 5 milligram of maintenance is okay. This is a multi-dose pre-filled pen. And It is temperature sensitive, so needs to be stored between 2 and 8 degrees. Now coming to another molecule, that is semaglutide, which works only on GLP-1 RAs, but in clinical practice, it almost translates to similar benefit like tirzepatide. And it now I would just I want to bring to your attention types of eating. We know that, eating used to be just eating a few years back. Now there are so many types of eating: homeostatic eating, hedonic eating, there is a binge eating, there is a, intuitive eating, and there are so many types of eating. But by and large, to know about these drugs, we just would want to know two types of eating: homeostatic eating, which is regulated by basically the hunger pathway. So these drugs act on the homeostatic eating, and there is hedonic eating. Hedonic eating means you just eat for pleasure. You are in a company of friends, and to tell you the fact, these food bloggers, they do a lot of damage. They do their job so perfectly that people who are not very fond of eating also want to eat in the random restaurants they speak about. So this is hedonic eating, eating beyond, hunger, just eating for pleasure, happiness. When you are happy, you eat. You are unhappy, you're stressed, you're anxious, you eat. So this is all hedonic eating. Basically, eating giving you a kick. So these drugs, they act on both homeostatic eating and hedonic eating. So, some youngsters, they describe this precisely. So how are you feeling after this drug? They would say that the foot chatter has stopped. I used to study at night, and there would be a constant foot chatter going in my brain, which has stopped. So exactly that is what happens. So the weight loss benefits, significant weight loss with Wegovy compared to lifestyle intervention alone, and a sustained weight loss of 4 years. Wegovy is semaglutide in the higher doses. Like semaglutide is marketed, it was started in India by Novo Nordisk. The smaller doses used in diabetes, approved for use in diabetes, are known as Ozempic. Then higher doses are Wegovy, and the oral semaglutide is known as Rybelsus. So beyond loss, what do they do? This is some semaglutide data, which is translatable to tirzepatide as well. There is reduction in the waist circumference. There is HbA1c reduction. There is HSCRP reduction. There is totally the inflammation goes down. And I myself have seen, grade 3 fatty liver going back to grade 1 in a matter of 6 months. So BP reduction of 10.9 millimeters of mercury diastolic as well as systolic, and triglycerides. So Wegovy has a simple and safe dosing regimen. Just like I told you about tirzepatide, same sort of dosing regimen and the same sort of precaution needs to be exercised in these molecules. If there is a side effect, you can stop at that dose, or you can withdraw and restart. So GI side effects, to my experience, whatever has been put on the label, the most common are a feeling of fullness. Some people do have nausea and constipation in the days close to the dose. And usually both these drugs are given once a week. If you happen to skip a dose, up to 5 days, you can give a skipped dose. But if it's beyond 5 days, then you have to consider it a fresh start. So semaglutide offers wide range of clinically proven benefits. We spoke about it just now. And there are some liver benefits, improving the MASH. We know that MASH is a big villain nowadays. metabolically associated steatohepatitis or liver disease. And across the spectrum of proteinuria, it has an advantage. And these drugs are more or less kidney safe. Unless the GFR is too low, it's safe to use these drugs, except exenatide, where we need to adjust the dose in renally impaired patients. Now, considerations prior to prescribing. Gastrointestinal effects were predominantly mild to moderate in intensity. But having said that, a serious side effect, which is on the label, is acute pancreatitis. So a person who has suffered from acute pancreatitis prior or acute pancreatitis with the drug should be an absolute no. Renal impairment, unless the creatine clearance is less than 30 ml per minute, you can use it in the same dose. By and large, there's no dose adjustment that is required, but end-stage liver disease and end-stage renal disease, better not to use. And these are the considerations. And one more thing I brought to your notice earlier, that is a family history of medullary carcinoma thyroid. And some endocrinologists wish to have an ultrasound of thyroid and abdomen just to look for cholelithiasis and thyroid swellings or nodules, just to make doubly sure, although it is not included in any scientific protocols. Now, again, the consideration I spoke about pancreatitis, using caution, inform patients that whenever you have an acute abdominal pain, get back to the treating doctor. And comorbidities like type 2 diabetes, you may need to bring down the dose of insulins and sulfonylureas when you are using this drug, especially when the patient has started losing weight. Please remember, it is not an insulin substitute. Insulin needs to stay there whenever a patient is taking insulin. You may need to decrease the dose of insulin eventually as you progress in the journey with GLP-1 RAs, but it is not an insulin substitute. It is not used in type 1 diabetes also. Monitor patients with diabetic retinopathy or potential. You might have heard of a couple of complications, that is worsening of retinopathy and something known as anterior ischemic optic neuropathy. But the Indian studies that are happening on semaglutide are saying that a worsening of retinopathy happens due to an extreme change in the glycemia status. Probably the ophthalmologist in the group would know that whenever you have an intensive control of glucose, there is a worsening of retinopathy and neuropathy. So it is this intensive glycemia control that is contributing to increasing incidence of retinopathy and the anterior ischemic neuropathy. There is no cause and effect relationship as of now. Now, in use in PCO, the drug is very useful in PCOs, obese PCOs, where you want to bring down the weight and the patient wants to conceive. But it has to be discontinued 2 months prior to planning pregnancy. Absolute contraindicated in pregnancy and breastfeeding. So these are certain eating habits. Eat small meals, not very spicy. Then good clear drinks. Then low-fat diet, lot of fiber and proteins. Another concern with these drugs is that as you lose the fat mass, you might be losing some muscle mass, which is known as sarcopenia, and that's something we do not want to happen. So if we do not want this to happen, what we should emphasize to the patient is eating plenty of protein and regular exercises, including weight training or resistance exercises. So that would minimize the chances of sarcopenia. We know that sarcopenia happens even when we go on a crash diet, dieting only regimens, people lose weight by that without exercising, you stand the risk of having sarcopenia. So by having a proper exercise schedule, you can, to an extent, limit sarcopenia. Protein, lot of fiber, good hydration. These are some nutritional recommendations with these drugs. Resistance exercise, weekly 150 minutes of moderate intensity. We spoke about all this. And these are some things that, one thing is people who had a sweet tooth, who had a craving for high fat food, they stop having these cravings. To an extent, this is very beneficial. You generally, the people, they when they think that I cannot get my hand off a sweet, they really stop taking sweets, and they no longer have the craving for sweet. So these are some tips, and these are some experiences. These are the two molecules right now we have as once weekly injections. Semaglutide, we also have an oral preparation. Tirzepatide, we nearly have a experience of more than 5 years. And the mean weight loss documented by tirzepatide is around to the tune of 20%. That is, 100 kilo person would turn 80, and nearly the same with semaglutide to the tune of around 15 to 18%. So these are some organ-centric benefits. The organ-centric benefits, I'm sure, are a class effect. Only thing is, semaglutide has more evidence in its favor in terms of benefits in cardiovascular disease, kidney endpoints, and MASH resolution, and no worsening of fibrosis of liver. Now, we are done with the pharmacotherapy. Coming to types of gastric surgeries, we have sleeve gastrectomy, Roux-en-Y bypass, and gastrojejunostomy. So these are the few bariatric surgeries where the weight loss and type 2 diabetes remission were observed following vertical sleeve gastrectomy, Roux-en-Y gastric bypass, and biliopancreatic and with duodenal switch. So these are other things which would contribute to meaningful weight loss. And this is how the weight loss chart goes. And we can see that the weight loss with bariatric surgery is almost comparable to the newer GLP-1 RAs or anti-obesity medications to the tune of 20%. Some of the studies with bariatric surgeries, they document a weight loss of more than 25%. Now, this is the latest guideline for obesity management. You can see that, you classify as body weight management in obesity with no complications and complications. So when you have complications, you have fat mass diseases like osteoarthritis, obstructive sleep apnea, and sick fat diseases, the serious ones, that is prediabetes, diabetes, cardiovascular disease, heart failure, and MASLD. So most of the places, whether you have only body weight as an issue, where you have fat mass disease, and where you have a sick fat disease, everywhere GLP-1 RAs figure. So this is a very, very busy slide. I don't want to go into details. Just would suffice to say that there are a lot of extra benefits apart from losing, weight. And there has been a concern regarding depression, especially some studies from Australia after using GLP-1 RAs. But we know that depression and social withdrawal is a part of obesity. So we need to assess the psychological state also before putting the people on this drug. And this drug certainly has an action on the reward pathways where the reward to eating good food is blunted. Similarly, the reward to some other pleasures in life also may be blunted. It's just an observation. There is nothing to prove it, and the Australian observations have been negated. So now the ADA recommendations that says that in people with diabetes and overweight or obesity, the preferred pharmacotherapy should be glucagon-like peptide 1 agonist or dual, that is like drugs like tirzepatide. And metabolic surgery can be considered in more than 30. I would just like to highlight on the recommendations. Anybody who is above 30 without complications, and anybody who is more than 27 kilogram per meter square of BMI with one of the lifestyle diseases like diabetes, hypertension, obstructive sleep apnea, dyslipidemia, etc., can be a candidate for these drugs. Now, the biggest question: when can we stop the drug? Lifelong? As soon as you say lifelong, few of the patients would never turn up. So don't scare them. Tell them it is a long-term therapy, because it's a fact that obesity is a relapsing disease, it's a long-term disease. You may need to continue the drug. So the data says that the metabolic adaptation achieved were with total withdrawal, tirzepatide, and continuing the maximum tolerated dose was studied. And what happens? 96.5, this is over a period of 60 weeks. And a continued maximum tolerated dose could maintain the weight loss to the tune of 96.5%. That is, an absolute regain was 0.2 kilogram. Practically no weight was regained if we maintained the patients or the persons on a maximum tolerated dose, which is not doable in clinical practice. So we would be reducing the drug to the lowest possible. So what happens when we give a maintenance therapy of 5 milligram of tirzepatide? 42.4%, that nearly 50% maintained a more than 80% of weight loss. The absolute regain was to the tune of 6 kgs. And when you totally stopped, whole of the weight was still not regained, but only 10% or 11% maintained a more than 80% of achieved weight loss, but some weight loss was all the same maintained. There was a regain of 10 to 12 kilos. So this is the story of GLP-1 RAs and what we could do with the newer drugs to something as relapsing, as chronic, and as troublesome as obesity. So this is the global threat now, obesity, and it has put everything else behind it, including global warming. Thank you very much for this opportunity, and hope a few of you at least got a hang about the GLP-1 RAs. Thank you.
Thank you, Dr. Sonia, for the wonderful presentation. Now the topic is open for discussion.
Got any questions in the chat box as well?
There are no questions seen.
Can I ask a question?
Yeah, please, sir.
Can semaglutide be started as oral therapy from the beginning?
Yeah, of course, sir. Semaglutide can be used as a oral therapy. There are people who don't like injections. We can start with 3 milligrams of semaglutide. Similarly, it should be taken empty stomach with half a glass of water, and refrain from eating or drinking at least half an hour to 45 minutes after that. And gradually we can increase to 7 and 14 for people who do not want injections.
Is there any difference in tolerability? I mean, intolerance between parenteral and oral?
Intolerance. No, not much, sir. Because the biology is the same, there is not much difference. As you go to higher doses, some people do have gastric intolerance, both in injections and the tablets. It's almost the same.
Thank you, Sonia. It was a wonderful presentation. Thank you.
Thank you, sir.
Sonia madam, I heard this
Yes, sir.
semaglutide therapy will cause more incidence of colorectal cancer. Is it true or?
Sir, actually, I do not know about it. I've not heard of it. So
I
far,
read in a Medscape article
Okay.
regarding semaglutide therapy, colorectal cancer incidence is more in patients long-term therapy.
Okay. So probably, it needs further validation. I'm not aware of it, sir. Madam, Lata madam, any
No,
takes
yes,
on that?
Like how the major issues is the GI issues. Some may have constipation, gastritis, those are the things which is discussed maximum. This is what we have seen. And similarly, like how Dr. Sonia said, the ischemic optic
Neuropathy. Yeah.
that also it's something which is like how madam said, based on the sudden variation in the sugars. But same, I have also not. Only thing is regarding the multiple endocrine neoplasia and thyroid malignancy, family history, we have to be careful. Regarding colorectal cancer, I'm also not very sure about it. Maybe it could be less of colorectal cancer. Otherwise, also with constipation and the diet which is less in fiber and all, is itself has been implicated as one of the risk factors for colorectal cancer. So I will have to see. I'm also not very sure about that. It's like when a magic pill has come, so everybody is like they just want to take and reduce their weight. But definitely the emphasis on the lifestyle modification and a correct diet with the need for the required amount of protein, fiber, all those things has to be stressed. Because what the thing is, you open the social media, everybody, we are seeing the film stars, we are seeing so many people who are just losing weight. So everybody is like, now even we can use. Previously, I think cost was a factor. Now, once the patent is over, all the companies are coming up. with the medication. So definitely it is becoming more less costly. So more and more people can afford it. So it's more or less like a magic pill. Definitely, it is a wonder pill, but the lifestyle modification, diet, and exercise should always be one of the cornerstone in obesity management. That's what I feel.
Eris company marketed injection for 160 rupees.
Yes, yes, sir. There are basically the original ones are biologicals. So they
Biologicals.
are, the manufacturing process is very costly. But we have a lot of synthetic variants where, one person came and told that one dose would cost just 250 rupees a week. So synthetic versions are coming up. So we really have to watch out whether the synthetic versions are as good as the biologicals or biosimilars. There's always a concern.
Yes, yes.
The
What about
original people would
dapagliflozin,
say that
madam?
no,
Have you got
synthetics
any
have.
idea about dapagliflozin?
Yeah, of course. Dapagliflozin also helps in weight reduction, but in non-diabetic patients, in cardiac failure, it can be used even in non-diabetic patients. But as an anti-obesity drug, it is an off-label use. I don't see any literature to that effect. So dapagliflozin, in my clinical practice, I feel that it really gives very meaningful weight reduction to the tune of maybe 3 to 5 kilos, sometimes more even. But it is not an anti-obesity drug. It is a cardiac failure drug or it is an anti-diabetic where you have an additional advantage in terms of weight loss.
Yes, yes.
And can you give
Thank
it
you,
in obese children? Is there any age cutoff for?
Sir, the current data is above 14. There are some data about 12 also.
The secretary also?
FDA approval is about 12 years of age.
12.
And regarding the colorectal cancer, recent studies has shown that actually it reduces obesity-related cancers, including colorectal cancers. That's the most recent finding.
Is a pre-existing gallstones a contraindication for semaglutide?
No, it is not, sir. It is not. But we have to keep the patient, we have to inform the patient that if an acute abdominal pain happens, you have to immediately respond or seek medical help. It is not a contraindication, but all the same, there is a concern when you have gallstones. It's not an absolute contraindication.
Thank you.
Dr. Deepa, probably we are done.
Yeah. think there are no more questions. Even in chat box, nothing is there.
Madam, excellent talk, but can you give us your experience in type 1 diabetic patients with the use of these drugs?
No, sir. It's It's not indicated in type 1 diabetes. It is not. It is not a insulin substitute. In obese type 1 also, it is not indicated. So far on the label that is said that it is not to be used for type 1. In fact, a couple of, obese type 1s came and asked for this. They wanted to try out what will happen. I mean, but probably we cannot encourage what is not there on the label.
Thank you, madam.
If there are no more questions,
I think.
thank you, Dr. Lata, for chairing the session. Thank you, Dr. Sonia, for that excellent session. So crisp, but you have covered touched upon almost all the aspects of obesity. And thank you so much. I'm sure that all of the participants have benefited from the session. So let me invite Dr. Vinod for an official vote of thanks.
Thank you, ma'am. I think there is an issue with my network. I'm unable to play whenever I'm connecting by turning on my video, it's the sound gets disrupted. So anyway, for officially, I would like to express gratitude to IMA, AMS, KSB for organizing this session, and a particular thanks to Dr. Sonia Suresh for her presentation and Dr. Lata Rajivan for moderating the session. And thank you, our chairperson, Dr. Deepa, and President MN Menon, sir, and all other dignitaries and senior doctors who attended the session. Thank you all.
Thank you, Dr. Deepa. You, as usual, you do everything with a degree of perfection, almost perfect in whatever you do. So hearty congratulations and thanks, Lata Madam. Thanks to all the participants. Thank you.
Thank you, one and all. Good night.
Thank you. Good night.
Good night.
Good night.
Good night, all.
Good night.